It's slowing us down a little bit, but I really appreciate everyone staying this morning. I, of course, am Karen Luce. I am your facilitator for this morning and this afternoon or this evening's webinar, depending on where you're at. And thank you for joining us. Today, our topic is Culture and Change Readiness at the Adventist Health System. We're very happy to have Dr. Phil Smith from Adventist Health System with us. This is the second of our two-part series on culture change in healthcare. And before we get started, I really quickly wanted to go over a couple of technical things. We're going to present for about 40 minutes and then use the remainder of our time to answer some questions sent in by you, our audience members. On the right-hand side of your screen, you're going to see a control panel, and you can use that to send in your questions. There's a little chat box there. We encourage you to send in your questions throughout the presentation rather than waiting for the very end. That way I can take a little time and organize those questions and then use or make the most of that question and answers time for us. We do apologize if we don't get to your specific questions, but we will try to follow up with you at the end of the webinar, and we'll really make the most of that question and answer series. I also want to let you know that a copy of today's webinar and the PowerPoint slides will be archived on our website. So if you'd like to view them again, they will be available for you, and we'll send everyone an email once they're ready. So now to get started, I'd like to introduce to you Dr. Philip Smith. Dr. Smith is the Corporate Vice President and Chief Medical Information Officer for Adventist Health System. Phil has led the vision and design for a commoditized rollout of the CPOE process for the hospital system. That's Computer Provider Order Entry system. He also served as the Vice President and Chief Medical Officer for the Florida Hospital, Zephyr Hills, for 4 years. Prior to joining Adventist, Dr. Smith served as a clinical advisor and helped numerous hospitals and large healthcare networks implement clinical information systems, including CPOE. We're very excited to have him here with us today, and with that, I will turn it over to Dr. Smith.
Thank you, Karen, and hopefully everyone can see my slides. And I'm going to start out with talking about what the heck am I actually talking about. And we call this computerized physician or provider order entry. And since some of you may not be in the healthcare industry, I'm going to do a little primer on CPOE so that you understand it. But what it really means is that the physician is going to be entering their orders in the hospital into a computer rather than writing them. And I always like to show this slide because this is what I call our anchor slide for our project. And it really is a very clear demonstration of what the prior state was prior to doing CPOE, which is we bet patients' lives on the ability for us to get the orders right based on that handwritten order that you see on the screen. And I think most of us would recognize, even if we're not in healthcare, that there's inherent challenges of trying to interpret the medication correctly and giving it to the patient in the right dose and the right route, and also making sure that we are using clinical decision support to be able to capture mistakes before they happen. So the interesting thing of this particular slide is this was taken from an actual patient chart. The thing I love about it is the fifth medicine down on the handwriting actually had a question mark next to it, which the doctor put on the order, which means he didn't even know how to spell it. Hopefully he knew what the medicine was and that he was ordering it, but we can only guess what the question mark really indicates. And the circles that are on there are all violations of a major patient safety initiative, which is called using leading zeros, so that when you order something in a decimal dose, such as the drug at the bottom is actually 0.125 milligrams, that should actually be written as 0.125 milligrams, so that the dosage of 125 milligrams is not given as a dose instead, which would be a 1,000 times error. Of course, we could all argue whether or not you can figure out that that scribble after the 0.125 is actually a G for grams or an mg for milligrams. I'm still leaving that one up to interpretation. But I think we can see at the bottom that there's inherent improvements in a system where the orders on the front end are communicated by the doctor directly into a computer and are clearly indicated as not only legible, but they are complete with all the information such as the right dose, the right route, and when to start the medicine. The other thing that may not be inherent to the person not in healthcare is that when an order is confusing, we really begin our process with what we call the morning huddle. And this was actually nurses standing around at the nursing unit saying, what does Dr. Smith really mean by these orders? And you say, well, what do you think he thinks? And someone else says, well, why don't you call him? And then the nurse says, well, I saw Dr. Smith earlier, and he's not in one of those moods, so let's try to figure this out before we call him. Or he's a surgeon and he's in surgery. And so the ultimate response to that is they fax it up to the pharmacist, and then the pharmacist sits around, and two pharmacists will converse to decide whether or not anybody knows what the order is really intended to do. And ultimately, either someone makes their best guess or someone actually calls the doctor back. And you can imagine the conversation an hour later with Dr. Smith saying, well, Dr. Smith, do you remember that patient you saw in room 2103? The fifth order you went down on the sheet, you wrote a question mark and something that starts with an A. Can you tell me what you intended with that? And, of course, Dr. Smith's going to respond, why are you calling me? And if I didn't know it an hour ago, why do you think I know now? So it really gets almost into an antagonistic argument. And the second thing is the patient is the one being held hostage to the fact that at this point, this is a new order for a new medication. And I like to use the cliche that we run hospitals, not Hiltons. And so at a hospital, it's very important that this medicine actually get to the patient. And all this inefficiencies that's developed as a result of the paper order is keeping the patient from getting the first dose of medication. So if this is a patient being treated for an acute heart condition or pneumonia and we're delaying antibiotics or a medicine for the heart while we go through this regimen of trying to figure out what the order really is, the patient in the end suffers from this. So we have, as a health system, made a commitment for patient safety to roll out computerized physician order entry to our hospitals. And we're going to talk today about the change management process of doing that. So the first part of our change management process is making sure that we have a consistent message that is communicated to all stakeholders. And as you can see, this is our anchor slide, as I said, because even the layperson, a board member, or a patient can look at this slide and understand the difference that a paper order presents to a system as opposed to the communication that occurs when the order is clear on the front end. So anytime someone's wondering why we're doing it, we always bring them back to this slide. Because if they're questioning this slide, they probably are not going to get on board. But it's a little hard to make the case that the handwritten order is a superior system compared to the system of clearly communicating the order on the front end. The next thing we do is take them through the why we do in CPOE, and we really want to emphasize the concept of patient safety. And there have been several studies that have looked retrospectively and prospectively of does CPOE provide benefits. And through the years, there have been articles come up with horror stories of this happened at this site, and the industry very often in a new technology yells out anything that goes negative, and they sometimes forget that there are positives. And what we do in the design of CPOE systems is make sure that we engineer out the things that have brought other health systems to their knees and build true patient safety into the system. And so we communicate to all the stakeholders that we're looking at through major studies who have been done by very reputable people that we're somewhere in the mid-80% reduction in med errors, and that includes near misses that never reach the patient. But when you look at med errors that actually reach the patient and cause harm or death, CPOE has been shown to reduce error by 55% of those categories that are severe enough to cause the patient harm. And so notice that the goal is not 100% reduction in medication errors, because we still have about a 45% human factor in CPOE and people trying to work around the system and not doing it correctly. But a 55% reduction is pretty significant in an industry that is quoted that we have about somewhere between 45,000 and 98,000 deaths per year due to preventable medical error, and another 750,000 patients harmed each year by medical error. And if you want to put that death figure into perspective, 98,000 people a year dying of preventable medical error is equivalent to a fully loaded 747 crashing every single day in the United States. And if we were having that level of aviation safety, I think we would be doing something about it. And so CPOE is the equivalent to the National Aeronautical Safety Board, which is getting safer systems in on the front end to protect our patients. And the other aspect of this is what we call clinical decision support. And that's the ability to monitor what's going on during the ordering process and giving direct feedback to the ordering prescriber or provider, the concept that this may not be the right dose, or it may be a drug that the patient's allergic to, the patient's already got a similar drug ordered, or the dosage is out of range for what's appropriate for the size, age, and weight of the patient. And so our clinical decision support, just in the first 2 months of the year, we have seen over 10.3% of the medication orders that are entered by physicians, that the alert system is actually influencing the physician to change their prescribing habit. And that means they either stop the order, they modify the order, or they add additional monitoring medication or study onto the order to make sure that the patient gets ultimate safety. So that's a huge number. And just to give you a perspective, since January of 2010 through February of this year, we have placed 7.7 million orders by CPOE. So that's a very, very large number of care. Just a little bit about us as a health system. We're a 43 hospital health system owned by the Adventist Church. Our commitment is, our mission is to extend the healing ministry of Christ. These 43 hospitals are located across 10 states. So we have 24 hospitals in the state of Florida. We extend all the way up into the Chicago market and Wisconsin, and as far west as Colorado. So we're mainly in the southeastern United States, the Midwest, Texas, and Colorado, and Kansas. So we take care of about 400,000 inpatients a year and about 6 million patient visits a year. So that gives you a little bit of scope, and we're estimated to be the 10th largest health system in the United States. And when you look at the numbers, there are about, we probably take care of about 1% of the inpatients per year in the United States, to give you kind of an idea. A little bit more about CPOE. We have seen efficiencies around reducing callbacks, and callbacks are when the doctor has to be called back by the pharmacist, and we've seen a 94% reduction in callbacks. And so callbacks are, again, represent delays to the patient getting the medication. So by eliminating those, we improve efficiency. We obviously reduce delays due to illegibility because we don't have any written orders in the CPOE world. And we actually have seen doctors that report usually from 5 weeks to 5 months that they actually are rounding faster using the CPOE system along with online physician documentation as compared to doing handwritten orders and handwritten daily progress notes. We see a dramatic change in communication, and there's also a program that was formed out of the stimulus plan, the ERA, the American Recovery and Reinvestment Act that was signed into law by Mr. Obama. This provides about $18 billion to hospitals across the nation and doctors to adopt advanced clinical technology in the healthcare space. So it's providing incentives for the next 4 years to hospitals and doctors to actually do CPOE to help defray the cost of it. And that amount varies. And starting in 2016, any hospitals or doctors who aren't doing CPOE will actually see a reduction in payments through the Medicare and Medicaid programs in the United States. So there's a big movement towards doing CPOE. Fortunately, we had started our project about 5 years ago in planning, and so meaningful use has not been a external driver for us as much as an interesting thing to leverage as we move forward, because our planning and start of our program actually began before meaningful use was actually passed into law. But we think it's going to move the industry in a way. Our biggest concern is there aren't enough people out there who can manage the change around CPOE, and about 70% of clinical IT projects fail, and it's usually because they haven't attended to the change management involved with it. So the next slide we actually use to communicate to the sites, because if you're a novice to CPOE, you probably think that CPOE is really about the ordering process. But the fact of the matter is, the physician order is really the requirement for almost everything that happens in a hospital. So if you think about it, no patient is admitted to the hospital without a physician order, and every intervention done during that hospital stay is initiated by a physician order. So since everything in the hospital begins with a physician order, if you change the ordering process, you actually change all the processes downstream from that order. And so we communicate this slide, and we do it in great detail to our hospitals to help them understand how CPOE is not just about impacting the doctors, but it's going to impact everyone in the hospital, except maybe the cleaning people and maybe the volunteers. But in fact, we've even had cleaning people that say that in a CPOE environment, patients get out discharged quicker, which means they're actually able to clean that room for the next patient faster, and so patient throughput actually improves. So it really does impact almost every process in the hospital when you do CPOE. And I hope you get a chance to appreciate the complexity of the slide, but this is just kind of a taste how we disrupt the paper process when we go to the CPOE process. So in order to be successful to do this, and we now have 20 hospitals live in CPOE, and of that, just to give you an idea, we brought 2 hospitals live in 2009 just to prove our technology worked, and then in 2010 in April, we started our CPOE rollout, and subsequently, since last April, have brought 18 more hospitals live with CPOE. So we'll talk a little bit more about that in detail. But how we do that is really a 7.5-month project, or 8.5 if you look at support. So we actually go into a hospital, and we spend 90 days assessing the culture and their readiness to be successful in CPOE. Then we, through that time, we develop a communication plan. We do a stakeholder analysis. We assess the culture using the dentist survey. We do interviews, and we basically set up the theme and success for the project, get their board, the community board of directors on board, and then we have an official kickoff 90 days later. Then our actual CPOE project, which is our engagement of everyone, really occurs over a short period of time. Because of this 4.5 months, the last 6 weeks of that is actual training of the end users. So we really only have 3 months of active engagement with the users to move them from accepting the way they've done it their whole lives to a whole new paradigm of how they're going to practice medicine and healthcare within the hospital walls. And then we go live, and we provide on-site support for 28 days. But the truth of the matter is, it's really the first 2 months where most of the change occurs with CPOE. So during that first 2 months, we go through a process of what we call process stabilization, and then we begin to see through the transparency of new processes that we have opportunities to optimize the workflow and process, and then that's when we really truly get the benefits of CPOE. So our methodology is during these first 90 days, we start with a 4-hour executive workshop, because CPOE, though we're impacting physician care, the most important stakeholders for success is really the executive team, because they're the ones that own the operational success and the vision of the hospital. So we lay out the 5 W's and the H to them, and as with any major initiative, the why is the most important, and we take them through it in a little more detail than I have for this talk, but I think you get the idea. Is we want them to have an emotional connectedness to why we're doing CPOE, and we're not doing it just to do it. We're doing it for ultimately patient safety, and that is our message. And then during that workshop, we identify change management champions in different areas for the project. And we want these people to be directors and above so that they have the appropriate amount of authority, power, influence, and accountability within the organization. So our champions are divided into a workflow champion, communication, and so on, as indicated with this diagram online. And the only one that's not required to be a director or above is really the knowledge management champion and, of course, the physician champion. The knowledge management champion, their role is to keep an online repository of all calendars, presentations, communications, and basically the on-site reference library for the project. And then the community patient champion is a non-hospital employee. It has to be someone who doesn't work for the hospital or the spouse of a hospital employee. They have to be truly independent. And they become the Jiminy Cricket or conscience for our project. Typically, it's a lay board member who has an interest in the community, who understand. We bring them along to help them to understand why we're doing CPOE, and they're often the ones that question why we're trying to hang on to our old processes when conflicts come up between the new processes and the old processes. And I would say some of our community champions have been more engaged than others. I think this is probably an area where we could do better with, but I think the concept of it is very critical. The physician piece of this varies, and it could be as small as one physician. For a hospital with 720 physicians on staff, we actually have a team of 22 physician champions representing various specialties. So this is an area where we have a lot of variation. But these champions meet monthly. We openly keep people accountable for maintaining their piece of the project schedule and making sure we're hitting our milestones. And we have very frank discussions at those monthly meetings to make sure that true accountability is held. With this 4-hour workshop, we follow that with a whole day of interviews of the workshop attendees. And we have 6 basic questions that we ask each attendee in private, asking them what do they see as their role in CPOE, what do they see as barriers, what do they see as challenges, what broken processes they think are going to be uncovered, and what's your business case locally for being successful with this. And through that, we help to determine the attitudes and beliefs of the people that are going to be leading the projects, and also what's the local business case and their worst fears. Are physicians going to walk out of the hospital? Is there going to be danger in doing this? And the question is, yes, it will be inconvenient for doctors. This is a major change in workflows, and we represent community hospitals, so the majority of our hospitals are not do not employ the majority of their medical staff. They're independent people that have other choices of where they can practice. So it's of significance that we really need to sell them on the patient safety aspect and make sure that as we implement CPOE, physician inefficiency is minimized so that we get them back to their pre-CPOE efficiencies or better after we implement CPOE. So it's important to get the buy-in of the medical staff as well as make sure they're well trained. Usually within a week of this, we administer the Readiness survey. We administer that to all the management teams, so these are managers, directors, and vice presidents. We also do a grouping around medical staff leadership, which is typically 5 to 8 physicians at a hospital. And the medical staff is led by a group called the Medical Executive Committee, who are elected members of the medical staff. And they have various roles. One is called the Chief of Staff, which acts as the elected president of the medical staff, and then usually a leader over each service line, such as medicine, surgery, obstetrics and gynecology, and maybe pediatrics, and emergency room radiology and pathology. So that's pretty much your leadership of a medical staff. And in administering the Readiness survey, in addition to the standard Readiness survey, we have added some free text questions. And the one that's been the most valuable to us is what in your role at this facility keeps you awake at night. And we have found this very helpful, and it serves as the ability to validate what we're seeing on the Readiness It also helps to uncover some issues that we might otherwise not uncover with interviews and other interactions. And in fact, we have found that this has been quite disarming, and we have had very honest responses from the management team. We typically get one person that says, I sleep well at night, thank you, but most of the other responses are really uncovering some things that really are the key points of pain in the organization that are keeping these managers, directors, and VPs awake at night, and they share that with us anonymously, and it's very helpful as we move forward. We also asked them, is the organization headed in the right direction? And that's on a 1 to 5 scale, so 5 would be strongly agree, 4 would be agree, 3 would be neutral, 2 would be disagree, and 1 would be strongly disagree. So obviously, if the management team is saying that a 4 or less, that is kind of a red flag if they don't think the organization's headed in the right direction. Or if they rate the next question, which is, would you want to be a patient here, less than 4, that's also an indicator that they may be unsure whether or not they would be a patient. And if your management team of your hospital is unsure, then that would be a real red flag for us. And then through this, we compile a readiness assessment of the facility, and we actually do a portfolio on the facility, giving background of the executive team, how they process information, what we see in the culture, and what do we see as the major risk to our project. And then we have an open meeting with this management team, and we actually go over the density results with them, the key things that came out of the questionnaires, the answers to their questions, and we reflect those back to the management team. And it's very important during this meeting that we even pay attention to the seating arrangement. One thing that I want is either a U or a circular configuration of the people, because if I walk in and find that the management team of the hospital is meeting in classroom style where someone gets in front of them and talks to them, I know that the dynamics of the team is probably not collaborative. So we actually physically will go into a hospital and disrupt their normal meeting room and rearrange the tables and chairs to put them in a U so that we can have an interactive conversation as we're reflecting back. And it's very interesting watching, is this make them uncomfortable or not? So every little clue that we have, we utilize in our assessment of the hospital. This allows us to customize our approach and our change management plan. Now, for those of you familiar with the Denison, you're probably saying, wow, these are pretty good results. This is a very typical where we're starting with at our hospitals. And because we have a very clear mission as a faith-based organization, you'll see that our typical hospital has what I call a very healthy right hemisphere, which is mission and consistency. And having done CPOE projects for other health systems, obviously, I have major concerns if I walk into an organization that has very low mission scores, because my experience is if you're not starting with everyone on the same page around mission, you probably should fall back and really talk about the mission and understand why that is. And it's usually because you have a leadership team that may be a dictatorial style where one person is overpowering everyone else, or you have confusion, role confusion. And so fortunately I'm working currently in a health system that has very strong mission and consistency and is usually pretty good in involvement. Our Achilles heel is really in creating change, and then sometimes we also see third quartile scores in capability development and organizational learning. But overall, creating change has really been the area that we can help the organization the best. So by building these champion teams, we have the ability to come in and bring in a methodology that they can use not only to go through this major change initiative of CPOE, but literally to help them through the process of bringing on a new service line, building a new hospital, or any other initiative they're doing. So we're encouraging our hospitals through this project to adopt good change management methodology so that as they move forward, they can have every project having a good, consistent foundation of not only a big why, but having a good stakeholder champion team, making sure communication, training, workflow, and so on are being equally dealt with throughout the life cycle of the project. So the dentist has been very helpful. And the reason we like these validating questions is we often come into a hospital that are darn good survey takers. And as we drill down from the composite down to the managers and directors versus the executives, and we look at clinical versus non-clinical, we often see areas that are really stressed in one area, such as a nursing unit that maybe capability development is very low, which means obviously they don't have clear development of their people, and we can identify that. But occasionally we'll come into a system where what keeps you awake at night has extremely poignant comments that make your hair stand on end, but yet their dentist scores are extremely high. We actually begin to deal with that openly, that are you guys pretty good survey taker? And usually they do confess at the leadership meeting that, yeah, they were answering that how they thought they want to be, not how they really are. And we feel like we get pretty good validation and expose this. So we did have one of our hospitals, however, that we got a call from the dentist organization that we had the highest scores ever picked up. And this hospital is in the top 50 hospitals in the country. And the moment you walk in the hospital, you know the culture is superb. And sitting through their board meeting, you realize that they discuss the serious questions at the board meetings about quality and safety. There's high levels of accountability. And I was very confident to be assured that their dentistry scores were going to be very high. But I was very amazed that they had the highest scores that Denison had ever seen before. And it was nice to be able to validate that, as opposed to other organizations that may totally fill out and be a top quartile in every measure, but when you really drill down to their organization, they have a lot of areas that's not a good reflection. And I know many of you that use the Denison use it in lots larger numbers with thousands and thousands of employees, but for our usage, we have used it mainly as a leadership assessment tool, and it's been very helpful in this context of what we're doing. And this is an example of a little more challenging hospital that we had to deal with. And as you can see, the mission is still pretty good in consistency, but we had major areas around creating change, team orientation, and empowerment. And so going in there, we knew where we needed to focus our efforts. We have since acquired 4 new hospitals in our health system, and in assessing them, we have some new challenges because their prior structure did not have a strong scores in the mission area and consistency. So we will have a little longer time period to do CPOE in them, and we will have a team. We do have a team on site working with bringing them along with our corporate mission to get that foundation built prior to doing this other major change initiative called CPOE. So we plan based on their CPOE readiness, and occasionally we do bring forth a recommendation that there need to be some key personnel changes in the leadership team, and we have fairly frank discussions about that. We do a lot of communication and team building, but more importantly, we want to empower the leadership and make sure that they're really empowered through this process. And it's amazing getting directors and VPs together on these monthly champion teams and having some very crucial conversations at times that may not be happening inherently in the organization around change, but we're able to see that, and it does in fact influence the organization. So our outcomes from all this is that we automated 14 hospitals last year and another 4 hospitals already this year. As of last Tuesday, we have 6 more hospitals to bring live between now and August 2nd. Our adoption rates, our goals have been to have at least 80% of the orders being entered directly into the computer by doctors and what we call mid-level providers, which are nurse practitioners and physician assistants, and less than 20% of those orders being verbal or telephone orders. And we've been able to maintain on the medication order. I looked at our data as of the end of March, and our percentage of med orders entered by providers is actually 87.6%, which means about 13% of our orders are verbal and telephone orders. So the doctors are very participative with this. We've been extremely high adoption rates compared to other healthcare systems that have done this. And we've achieved a reduction in adverse medication events, as well as improved turnaround time on what we call stat tests. And these are labs and x-rays that are ordered to be done within the next 15 minutes. We've actually seen a pretty good turnaround, about a 14 to 16% improvement in getting the results back completed and done. So in summary, before I open up with some questions, even though CPOE sounds like something that really is about the physicians, it's really about executive leadership, making sure they're well prepared to deal with the challenges, and then having the leaders lead the physicians because they will follow them. And so we understand that the culture, understanding their cultures help us to mitigate the risk proactively and be successful through this major change initiative that is going on throughout the industry. Currently, about 17% of hospitals have computerized physician order entry at some level, which means they may have one unit of the hospital doing CPOE. The majority of hospitals do not do what we call big bang implementations, where they convert the whole hospital on the same day. There are probably only about 4% of hospitals that have CPOE at the level that our 20 hospitals do. So at this point, I'd like to take a breather and see if there are any questions.
Well, thank you, Dr. Smith. We have had quite a few questions come in. Let you catch your breath there for a minute. One of the questions, we'll kind of start with some of the higher level questions here. One of the questions was, can you talk a little bit more about how your choice of surveying the higher levels of the organization and how you're assured that that's indicative of the staff culture and can show you the change readiness of the organization?
Okay, well, I hope in answering this I'm not creating any Denison heresy, but my theory on this is that this is a major emphasis that impacts, to a big degree, a group of volunteer, which we call the physician medical staff. They're not our employees. They're the biggest people we need to influence. And physicians are high influence, high power people within the organization, but they're not our employees. And so my biggest risk to doing a CPOE project is really executives waffling in their commitment when the medical staff comes in and makes major complaints. And this is a thing which we do present a major inconvenience to the doctors for a season. That season, if it takes 21 days to develop a habit, we know it's going to be at least 21 days. We know that it's at least 21 hours of patient care, and we know for some doctors it may be 3 or 4 months of disruption. So in being able to influence change and being able to do this with a very small team of people that rotate around multiple hospitals, I have to get the biggest bang for my buck. And so my experience in this field has said, if I can get the executive team and the leadership team all on the same page, they need to lead their rank and file downstream, and they need to be bolstered to be able to lead the medical staff. So it's really a logistical thing. When you go into a hospital in a short period of time, there's not even a location in a hospital where you can have a town hall with all the employees. Most hospitals can only manage direct communication, interactive communication with a small number of people. So it's very typical that a management team's about 42 people at a hospital that ranges around 100 to 150 beds. We have some hospitals in our system as big as 2,000 beds. We have as small as 24 beds. So we have to settle on a methodology. And we've been extremely successful with this model of going in and managing the management team and then helping them with the communications downstream to their unit level people. So we provide them with, in our communication plan, what we call CPOE minutes, newsletters, different communication tools so that they can carry the message down to the unit people. But I, as someone who come in with a very nice team of change management folks, we want to be able to influence the leadership team specifically because we do not have the manpower to come in or the time to come in and revamp the whole culture. And I'm kind of a fan, a student of John Maxwell, and one of his best quotes is, "Everything rises and falls on leadership, and leadership is influence." And I really believe that if you get the directors and the executives on board and bring the managers as well along as well as you can, everyone else will follow suit. If I was doing a project to change an organizational culture long term, I think I would engage everybody in the assessments, but I need to do the most bang for the buck in a short period of time to be effective. So that's how our methodology came about. I've been using this for now about 10 years, and have brought 28 hospitals live on CPOE with us and have not had any what I would call failures in that time. So it's working.
Okay. Have you ever had an opportunity to do like a before and after with the Denison to see how the scores have changed?
Yes. Actually, in this health system, I've only had one hospital. I believe for our thing, what my recommendation is to do it every 2 years. And I've encouraged hospitals to do it. At this point, I've only had one hospital that has been live long enough to really look at that. And that hospital actually had fairly low scores in empowerment and customer service. So in addition to bringing CPOE live, they actually did some specific work around empowerment, and this actually started prior to CPOE going live. And we looked at both the empowerment. Empowerment was in the first quartile, and customer service was in the low second quartile. And after intervening in both those areas, empowerment was in the third quartile, and customer service was in the fourth quartile. So I'm a firm believer that we can influence culture, improve scores, but you need to know where to focus. Fortunately, I'm in an organization where we don't have to spend a lot of time selling the mission, because the mission has been very well adopted, and people come to work for our health system because they like that faith-based environment. And so we see that not only in our leadership, we see that all the way down into our trenches of rank and file. So if you're dealing with a different type of organization, you have different challenges. And obviously, if your mission is off track, you need to expand your intervention to a larger degree of the organization than if you have the opportunity that I have, which is to influence an organization that has clear message, mission, and consistency.
Okay. Well, that actually brings up another question. You know, you mentioned in the presentation about mission. If an organization or one of your hospitals was low on mission, that would be very alarming. Are there any other particular areas in the Denison model that, if they were low, that would cause you alarm?
Well, I don't think any of them really cause me alarm. They just point out areas that we need to focus on as a team. So sometimes we come in and I'm going to share experiences from organizations bigger than just the Adventist Health System, but sometimes you're dealing with organizations where accountability is a problem. And so accountability, how does that typically show up? Well, it shows up in usually team orientation, and we also see capability development in organizations that aren't doing proper career paths and giving opportunities to employees. And when you really get into the organization, you often see not only is there a lack of a career path, there's often lack of accountability, and it's kind of a top-down type of structure. So we try to identify these and mitigate them. Our change management analysts have been extremely successful at even coaching executives on their technique of dealing with employees. One of the most obvious things is kind of a trend, and the Gen Yers on the call will identify this, is, you know, walking into a meeting where a director or a VP is on their BlackBerry during their departmental meeting. And that's a behavior that is an immediate red flag to us, because it's communicating to their team that you really aren't that important. My email is more important than this meeting. And, you know, it's a terrible example, but it's a very common thing in this Gen Y environment that people think social networking, you know, and they're not on their, you know, on Facebook, they're on there reading emails, but it's the urgent, unimportant things, as Covey would say, that they're dealing with and not dealing with the people. So we pay a lot of attention to the organizational behavior that we see going on during meetings and during interactions. And so in addition to the denizen, we're using a lot of direct observation, interviews, and really getting a good pulse of the organization. And then we actually, as we're doing our communication plan, we do a pulse survey every 8 weeks, and we ask the people in the hospital, you know, do you know about CPOE? Do you know why we're doing it? And if you were in charge, what would you do differently? And it's amazing how honest people are on these surveys, and they help us to adopt our better communication plan, because the first time we do that survey, we may find a whole group of people that are not, the communication are not reaching them. And so for years, the organization has been in the la-la land thinking, gee, you know, we really communicate well to our employees, but we come in and expose a group of people that never know what's going on. There is no trickle-down communication, and we have to deal with that. So I can say there's probably a lot of things that we've seen that we mitigate, and there isn't any one that really scares me other than an organization that doesn't have clear strategic intent and mission and vision. And it says in the Bible, without, you know, vision, people perish. And I firmly believe that. So if I walked in an organization that had low mission quadrant scores, I would really pause and start to understand that and start to impact that. And I had a hospital that only had significant scores in mission about 9 years ago that we did a CPOE project with, and they were saying that, gee, we want to build a new hospital 5 years. And in analyzing them, we found out that their executive team could never come to a decision about something. And so they would have meetings, and they would meet for 3-4 months processing a major issue, and at the end of 5 months, the CEO would say, okay, here's what we're going to do. And when I interviewed the executive teams at that hospital, and this was not in the Adventist Health System, but when I interviewed the executive team, what was one of the things that keeps them awake at night was, gee, our CEO never lets us make a decision. He always dictates what we're going to do. And I said, well, I've watched you guys. You don't make decisions here. You mull them around trying to get consensus, then you never get consensus, and then the CEO has to make a decision to move on. You are perfectly designed to get the results you're getting. So we created a new model for them, and we put them on a timeline, and we had a group of meetings every other week, and then we had a cabinet that met every other week, and any decision not made by the working teams on the even weeks got escalated to the cabinet at the odd week, and if the decision still was pending at the end of that meeting, the executive sponsor had ultimate authority to make a decision unilaterally. And we actually put that in place. The first meeting they had, the executive sponsor made one decision, and from that moment on, he never had to make a unilateral decision again. And they not only finished their CPOE project on time, they actually built their hospital successfully 5 years later using that model, and became an executive team that could actually function as an executive team and not a dictator style of leadership.
Wow.
So this stuff really works.
Wow. Well, that's wonderful. Well, thank you very much for being with us. I keep trying to call you Dr. Phil, too. Dr. Smith. I think that's about all the time we have today. I'd ask another question, but I don't want to run us over. So thank you very much for being with us, and thank you, everybody, for being with us today. I'd like to invite you all to come to our next webinar that's going to be on May 24th. We're going to feature Steve Fitzgerald and Roger Gaston from Avaya. They're going to be talking about culture change within their organization. And thank you, everyone, for joining us today. Again, an archived version of this webinar will be online later today, as well as a PDF version of the slides. So thank you very much, and we'll try to get all of your questions answered offline that we weren't able to answer today. And I hope you all have a great day. Thank you, Dr. Smith.
Thank you.